In today's video, we're going over a masterclass on patellofemoral pain. In the first part of the video, we're going over all the background information you need to know about this common knee disorder. And in the second part, we go over how you treat it. What does the evidence show to be effective? And what can you use as a physical therapist to improve your outcomes with your patients? Let's get it going.
So just starting with a little bit of background and a definition. So patellofemoral pain, I think aptly named, is pain around or behind the patella, so the kneecap, which is aggravated by at least one activity that loads the patellofemoral joint. So this could be squatting, this could be stairs, jogging, running, hopping, jumping, anything that's loading the joint. So, when someone comes in with knee pain, in order to give someone this diagnosis, you want to make sure there's at least one aggravating factor that's loading the patellofemoral joint. And we'll get into kind of how the biomechanics work there, but that's just a little background to orient yourself for what we're about to talk about.
Yeah, good stuff. And I don't want to give too much away because I know you're going to cover it, but yeah, it truly is pain kind of behind that kneecap, aggravated by those activities. And you're going to pick that up, obviously, in the subjective portion, but that's actually really important information to know. And later on, we'll talk about how you are a little bit more specific about maybe differential diagnosis, because we know this is a diagnosis of exclusion. So those are important little tidbits. You know, my patients keep telling me that they have pain right behind the kneecap. Hurts when they squat, hurts down the stairs. I think it's patellofemoral pain. What the hell does the research say about patellofemoral pain? PubMed.com. All right, there we go. Okay, excellent. There's 335,000 studies to read. Gosh, too much. I'm getting frustrated. Whoa, calm down. No need to be frustrated. This is Dan Pope. I have fabricated what I believe is the perfect solution to your problem. It is the patellofemoral pain evidence-based cheat sheet. And I'll catch you up to date on patellofemoral pain under 10 minutes. Well, I'll tell you what, Dan, that's actually pretty helpful because I'm kind of dumb and I don't like to read. Well, don't you worry, I'm dumb too. But when it comes to patellofemoral pain, I am not. We're going to go over all the greatest hits: definition, anatomy. What the heck is the pain generator? Are there any risk factors for this condition? What's the prevalence and clinical presentation? How about mechanisms of injury, differential diagnosis, how you even go about diagnosing this? And then our favorite, evidence-based treatment. So that's my promise. I'm going to get you up to date on patellofemoral pain under 10 minutes. I'll leave a link below in the show notes in the description. Go ahead and click on that link and get to learning.
Awesome. So getting into a little bit about the biomechanics of the patellofemoral joint. So when the knee flexes, the patella glides inferiorly. When the knee extends, it glides superiorly. So there is obviously a little bit of joint play that you'll find medial and lateral, but we primarily think of this as it will be equated to the train track sitting in the groove, right? Sitting in the track, the train in the track. So you'll hear that often kind of when you hear people talk about patellofemoral pain. So the kneecap has a little bit of movement in that patellofemoral joint as you're bending and straightening your knee. And then in terms of the joint contact surfaces, because this does change as the knee bends and extends. So initial contact between the posterior part of the patella and the femur, the track it sits in, starts around 30 degrees of knee flexion. So when you're standing and your knee is extended, you don't have much contact between the back of the patella and the joint there. And then the joint surface contact increases gradually between up until 90 to 120 degrees. So at that 30-degree flexion mark, you have some joint contact. And then the more and more you flex up until, if you're picturing a squat, say you're parallel or a little past parallel, you start getting maximal joint contact. And that makes sense because when you're talking with someone about what might hurt and they say, squatting hurts, but if I partial range, it's a little bit better. I kind of go deeper there and it's really, really painful. That definitely checks out. That makes sense. We know you have more joint contact there. And then there is a role of the quadriceps, right? So the deeper the knee flexion, we're probably getting some more compression at the patellofemoral joint as well. And we'll talk about the quad's role with muscle contraction because that's going to affect the biomechanics at the patellofemoral joint and contribute to some of these compressive forces. But that's just a little bit of background on the joint surfaces.
Cool. Good job, Kevin. I like that part.
Thanks, dude.
One thing I will say, and I don't think this has been parsed out too well in our medical literature, I'd like to see more of it. And the reason why this is interesting to me is because I work with a lot of Olympic weightlifters and CrossFitters, and obviously they're squatting as deep as they possibly can, right? The knee pain is very prevalent with those folks. It's usually one of the top three most injured areas, patellofemoral pain being the big one. You'll actually see some small, poorly controlled studies that show that Olympic weightlifters at international level have more patellofemoral arthritis by a good margin than regular sedentary folks, which a lot of that may be a problem with, it's a small study, wasn't really controlled well for things like body weight, body fat, so on and so forth. But that is a little alarming to me because we want these athletes to stay healthy long term. We know squatting deep does put a lot of stress on the patellofemoral joint. So I'm usually a gray guy. I'm not the person that says squatting is bad. I'm not going to say that squatting is like never going to cause any problems, right? I'm somewhere in between the two. How can we make squatting safer? As you descend into a bottom squat, obviously more and more stress on the patellofemoral joint. One thing you will find in our literature as well is there's something called a wrapping effect. That just means that when you get to the very bottom of the squat, the quad tendon actually is now within the joint, and that helps to dissipate some of those forces. So the contact area does decrease within the joint, right? So kind of the joint surfaces with the bone, the cartilage. But then the quad tendon actually ends up making an appearance, which may or may not be involved with quad tendinopathy, which we'll talk about at a later date, right? So that does happen. And the last piece at the very bottom of the squat is that your hamstring does bump up against the calf. Some folks kind of theorize that also decreases some of the forces in the patellofemoral joint because now you have those passive structures kind of bumping against one another. Anecdotally, I think most people do hurt as they descend deeper and deeper into the squat. They hit that hole. Sometimes they feel better in the very bottom, and then they start descending out of the hole. They're like, it feels like garbage. They get through the sticking point, and then it feels a little bit better. So I think that what you said is kind of spot on there, Kevin. Besides that very bottom part of the squat, which hasn't been studied especially well. So
Yeah. I just had a quick question. When you said that there seems to be a certain percentage of like Olympic weightlifters or power lifters with arthritis of the patellofemoral joint, um, do you know if they're clinically symptomatic, or do you know, is that just findings that the joint is a little bit more degenerative? Do you recall at all?
I want to say symptomatic. That's always the next question, which I think is good because people are like, oh, well, arthritis doesn't matter. There's no correlation with pain. But in a lot of these studies, they'll actually term severe osteoarthritis as folks that are at least eligible or have gone through with a knee replacement surgery. So their definition of arthritis is, probably spot on for people that are really hurting, right? As opposed to like, I don't know, if you have quite a bit of cartilage loss and you might not even know you have arthritis, right? And they take an image and like, well, it looks like you do have arthritis, but you had no idea what's going on. But I'd have to go back and read through that literature. Maybe I will leave a link in the show notes for folks to read. I went pretty in depth on this in my knee course because I really wanted to get some of those answers. It's like, is squatting actually bad for us? Because I work with a bunch of guys that are just hammering Olympic lifts all the time, right? And they may operate on this pretense of like squatting is always good for you. Well, in these extreme situations, sometimes, maybe not. Maybe not. I just say maybe because we don't know. But that's what the poor research we have is pointing to.
Awesome. So just continuing on the biomechanics of the patellofemoral joint. So the more joint contact surface is better at dissipating stress. So, when you are in that, 90 to 120 degrees of a squat, you have more contact surfaces with the joint, which doesn't necessarily mean it's going to cause pain. You actually want that because the more contact between the two joints, it's better at dissipating stress than when there's just a little bit of joint contact. But the more, when you're in that deeper squat position, you are getting more recruitment of your quadricep, and that also is going to increase stress through the patellofemoral joint. So, from a performance standpoint, it makes sense that when the joint is dissipating those forces, you're able to lift more weight. But if you do have an aggravated patellofemoral joint, it might come at a cost there. And then just to give you some idea about how much load is going through the patellofemoral joint with common exercises or activities we see with our patients. So this study was looking at that, and they were looking at as a percentage of body weight. So 1.3 times body weight is going through the patellofemoral joint, just walking on a level surface. So you're getting more than 1 times body weight there. 3.3 times body weight with stair negotiation, 5 to 6 times body weight with running. And so we didn't say this yet, but patellofemoral pain is also called runner's knee. So common injury in runners for sure. Probably one of the top ones. And then 7 to 8 times body weight during a deep squat. So, some pretty significant forces going through the joint there. And then we do have to always consider what's happening in the kinetic chain. So the way that some of our other joints move, your hip, your ankle, your foot, plays a role in stresses through the patellofemoral joint. And just one example I'll throw out there, just thinking about, weightlifting, is if you have a lifter with kind of poor ankle dorsiflexion and they're trying to get down into their squat, that extra motion has to come from somewhere. And they may be picking up more motion through their patellofemoral joint or through their hip as well. So, or, likewise, someone with poor hip mobility or hip pain with squatting, they may recruit more knee flexion. And then maybe we see more stress going through the knee with that. So those are joints we want to look at and see if it's something we could address in rehab. And then also just thinking about the active and passive structures around the knee. So, there are a lot of passive structures. You have your medial patellofemoral ligament. You have some lateral support there as well. And then obviously the role of the quadriceps, the role of the calf, the hamstring. So just looking at the big picture as well with these patients.
Yeah, for sure. And you already mentioned this, but you'll get into this, I'm sure, a little bit later, but we still don't really know exactly what creates pain in folks that have patellofemoral pain. Ends up being this diagnosis of exclusion. Maybe later on we'll figure out there are specific structures and maybe there's different structures. So patellofemoral pain does a bad job of classifying which structures are aggravated. There is a thought that some of those medial ligaments might become painful too. But the thought is that those passive structures help to stabilize the joint. And then maybe those passive stabilizers sometimes get aggravated too. But that's kind of yet to be seen.
All right. So getting into a little bit about who gets patellofemoral pain, like what types of patients are we seeing? How frequent are we going to be seeing it? So I thought this statistic was crazy. It said between 1.5 to 7.3% of all patients seeking medical care are seeking it for patellofemoral pain. So you think about our whole medical system and all the different things we see people for, and that's a pretty staggeringly high number. So this is a common thing. This is something you're definitely going to see. About 25% of all of the cases in an orthopedic setting may be surrounding patellofemoral pain. So that's about 1 in 4, that's wild.
That is crazy.
Yeah. 1040, Dr. 1040, he's out of Boston, showed that a lifetime prevalence of patellofemoral pain in high school runners is 21% for females and 17% for males. So again, runner's knee, and that's about 1/5 of all runners dealing with this at some point. Generally, we see this condition being more common in females versus males. It affects people across the lifespan. It kind of seems to depend on the study population, but we do see a lot of times that the numbers might be higher in younger athletes. So kids that are more active and maybe going through a period of rapid growth. We could wonder why. I wonder if it's just that the younger population is just generally more active, right? So they're doing more things that are putting load through the patellofemoral joint. But there does seem to be some correlation with the periods of rapid growth as well. So, a little bit of background there on prevalence.
Yeah, and like Kevin said, it's just extremely, extremely common. And one thing, and this is, lecture for another day, but I also see this somewhat continuous with patellofemoral arthritis. Because you're getting patellofemoral pain doesn't mean that you are developing arthritis. I'm definitely not trying to give that thought. But if you have a patient that comes in that has an anterior knee pain and they're, let's say, 50 plus years old, I start to think this might be some arthritis as well. So just make sure that's on your radar with your differential diagnosis. Not to say that folks with osteoarthritis can't get better with exercise and other treatments, but just something to think about some.
Just continuing with who gets patellofemoral pain, I thought these quotes were pretty interesting because a lot of times you'll see or hear physical therapists blaming patellofemoral pain on certain aspects about the patient or certain biomechanics that they display, and we're just not exactly sure what is the cause or the source of pain. Like Dan was saying, I think we're still trying to figure this out, but a recent systematic review of observational studies concluded that age, body mass, height, body mass index were not risk factors for the development of patellofemoral pain. Specific to the lower extremity structure, the quadriceps angle, also known as the Q angle, um, assessed either in weight bearing or non weight bearing, was not a risk factor for the development of patellofemoral pain. And I think this is something that's just been changing a little bit over time, because I remember in school learning that, we measured Q angles on people, and that was something that we might see, especially in the female population, that makes them more susceptible to developing patellofemoral pain. But at this point, we're still not sure. It doesn't seem like that is a causative risk factor. And then this other quote, patellofemoral pain is often believed to be related to excessive foot pronation. Overall, excessive foot pronation does not appear to be a feature across studies examining individuals with patellofemoral pain. So again, the consideration when you see someone who has patellofemoral pain in the clinic and they have excessive foot pronation, I think we want to be careful with how we word that to them, that this is something that is causative and now we have to fix it. We always want to just be careful in how we word things. I think when we talk about a future podcast that we're going to be doing on the treatment for patellofemoral pain, it does get a little bit confusing because some things like certain foot orthoses may be helpful in improving pain, but we still don't know for sure that this is the causative of pain. So I think it's important to tease that out so we can kind of word this the correct way to our patients, and not make them, worry about things that they probably don't need to worry about.
I know you're going to be talking about this a little bit in the next few slides, but I think what Kevin's getting at, and most people already know, is that dynamic knee valgus is like the boogeyman, right? We used to think that causes all of our problems, and that's still very much in the air, up in the air, excuse me, and up for debate. We're not really sure how much dynamic knee valgus is contributing to folks that have patellofemoral pain. I'm going to talk a little bit about in the treatment section, so I'm not going to go too crazy. But the thought is, if you're having dynamic knee valgus, so the knee is coming in when you're doing a squat, it lateralizes force on the patella, decreases surface area to dissipate force, right? And essentially, if I can get my knee lined up with my toe, and you can do that via trying to change foot posture. So if you have really flat foot, that's going to promote more valgus. If we don't have great control coming from the hip, or we're having pain at the knee, this can all create valgus. But it's very murky, right? So it's not clear cut. So if you're the type of person that's like, oh, knee's coming in, that's why you have pain, it's probably not true. There's probably a variety of factors, and it's not black and white whatsoever, which makes things a little bit more confusing, but that's the nature of it. Stinks, but we don't have all the answers.
Yeah, one last thing I'll say about that is I think I just want people to understand that going too far in either end of the spectrum there is probably not helpful, right? So if someone is demonstrating excessive knee valgus with certain things, and fixing that or modifying it helps the patient, then that's great. So we don't want to take the attitude that it doesn't matter at all, but we also don't want to, make people fearful about it. So I think it takes some nuance, and yeah, hopefully these just give you some things to think about. But further into diagnosis now. So how are we coming up with this diagnosis? I'll start with the bottom thing here because Dan has said it a couple times, but patellofemoral pain is a diagnosis of exclusion. So what that means is we have to rule out other diagnoses first. And I think the reason is that because we still don't exactly know what the pain producing structures are. So we have to clear a bunch of other things that we know it's not. And then we can feel better about the fact that it is maybe patellofemoral pain. But some other criteria that you want to think about, and I think this is from the clinical practice guidelines. So Clinicians should make the diagnosis of patellofemoral pain using one of the following criteria. So they should have pain either behind the kneecap or around the kneecap that they'll describe, and you can also palpate this, and you will see it painful in folks. There will be a reproduction of pain with something that loads the patellofemoral joint, such as squatting, stair climbing, prolonged sitting. I believe you could refer to that as moviegoer's knee. You might see that in the research. So you just picture, you're sitting in the movies for a long time. And I have memories of having this pain when I was in high school. Um, Tons of knee pain with prolonged sitting, like would be in a school assembly. And like, why is my knee hurting so much? It's definitely dealing with some patellofemoral pain. So you might hear that from the person, or just other functional activities that are loading the patellofemoral joint. And then again, that third one, it's a diagnosis of exclusion. So we want to rule out other causes of anterior knee pain, which I listed some specifics in a slide in a little bit later. So we'll talk about what other things to think about. And then the clinical practice guidelines does try to subcategorize patellofemoral pain a little bit. So maybe you'll see someone who fits in the category of a more overuse or overloaded patellofemoral joint. So maybe this is someone who is, very active in sports, weightlifting, that type of thing. So it's primarily an overuse issue. We may see a muscle performance deficit. So someone who presents with quad and hip weakness, we could categorize them in that group. That movement coordination that we talked about. So maybe they have that dynamic knee valgus that increases their symptoms. And we find if we modify that, it's something that could make them feel better. And then mobility impairments. So, maybe the patellofemoral joint itself has kind of poor joint play after surgery, or they're just, older, maybe like Dan said, some signs of arthritis. We want to maybe work on their patellofemoral joint mobility, and also just assessing the quads and the hamstrings for what the mobility looks like there, the rest of the kinetic chain. So that might help a little bit with how you're thinking about what bucket this person's in. Maybe it could help guide treatment a little bit. But these are just some things to keep in mind when you're trying to diagnose patellofemoral pain.
All right. I think one of the big ones you already mentioned is this is a diagnosis of exclusion. So largely you're just trying to rule out other more serious pathologies, or other pathologies are just treated differently. And I think the big giveaway is where the patient's pain is, right? So I have that anterior knee pain that could be a couple different things. So in the front of the knee, you're thinking maybe quadriceps tendinopathy, or maybe some sort of quad strain. If it's going to be above the kneecap. If it's below the kneecap, you might start thinking some sort of patellar tendinopathy, or you might be thinking Osgood-Schlatter's, something along those lines, right? Generally speaking, these folks have more diffuse pain. It's somewhere behind the kneecap. One of the other giveaways to rule out other pathologies is usually pain-free passive range of motion, although in some folks you may see some pain at end range flexion. These folks typically hurt in weight bearing, but when you have them sitting, it doesn't hurt unless they sit for prolonged periods, right? That moviegoer sign. I also do a little palpation to the medial and lateral structures, so some joint line tests, maybe a few meniscus tests, make sure there's no swelling, and then pretty much surmise this seems more like patellofemoral. And also keep in mind the history. So if someone says they had a big, twist when they were running, cutting, changing direction, big pop, a lot of swelling, that's a sign there's probably some tibiofemoral stuff going on. They need to get that checked out. If this is more of a gradual onset, maybe it wasn't gradual, it happened kind of all at once, but they don't remember any popping, swelling, and the pain is kind of behind the kneecap somewhere, kind of diffuse pain. It seems a little bit more like patellofemoral pain. Anything to add there, Kevin?
Yeah, that's good. I think one of the other ones that you might see, especially if we're thinking about runners and runner's knee, is a distal femoral bone stress injury. So again, that might present a little bit differently. Perhaps the mechanism is consistent high mileage in a runner, or they're adding a bunch of intensity. And I think for this, you probably see a lot more pain weight bearing. So even just without loading the joint so much like you would in patellofemoral pain, I think like single leg hopping or double leg hopping would probably really, really jack them up, where you'd think in patellofemoral pain that wouldn't be the most provocative thing. I also think I forget the sensitivity and specificity of this, the fulcrum test. I think it's not the best test, but it's something else we could throw in there as well. And then obviously when you just get a good history on their training and their diet, their nutrition, their sleep, it might give you a little bit of a lens into if they have a bone stress injury, if they had one in the past, maybe they're a little more susceptible to this. So that's another thing to just keep in mind. But I think like you had said, I think if you rule out the tendinopathies, which are different, they're going to have pain on the tendon. It's going to be pretty clear where their pain is. It's very localized, and they don't have swelling in the knee, so where it's not an intra-articular issue. Then we can be pretty confident narrowing down to a couple other diagnoses, and one of those will be patellofemoral pain. So hopefully, ruling out those other things, and then thinking about the diagnoses of exclusion, thinking about the location of pain and what activities are bothering them that are loading the patellofemoral joint, then I think you can be pretty confident in that diagnosis. That's one of the most fun parts of being a PT, I'd say. Working through that stuff's a lot of fun, you know. All right, so getting into a little bit about the clinical presentation and the subjective report from the patient. So again, just they're going to be complaining of pain around the kneecap or behind the kneecap that's worse with loading. So just keep those biomechanics in mind. Um, Aggravating factors that you're going to hear them talk about are, again, activities that load the joint, perhaps that prolonged sitting. And then how frequently are they having these types of pain? So Collins and colleagues reported that 93.7% of patients reported pain with squatting who had patellofemoral pain. So, that's pretty staggeringly high. I think that's something when you're thinking of diagnoses, you want to hear. 91.2% reported pain with stairs. 90.8% reported pain with running, and 81% reported pain with prolonged sitting. So, you're hearing these things, and I think you're feeling more and more confident this is what you're dealing with. Things that ease the pain in the patellofemoral joint, probably rest, right? When they're not weight bearing, when they're just hanging out, they're skipping leg day, they feel a little bit better. They're doing something like swimming rather than running, the knee feels a lot better. Again, making you understand this is a mechanical issue, and you're thinking, yeah, this sounds like patellofemoral pain.
Good stuff there, Kevin, as always. Yeah, one of the things that I mentioned previously, but we'll just double down on, is just that subjective history, right? We don't really have great special tests, spoiler, for this condition. It is that diagnosis of exclusion. So some of that subjective information is going to be very, very important. So make sure you're asking those questions, and you can start to tease out patellofemoral versus something else, right?
Okay, and then objectively, we've talked about these things, but when you go through your examination, you're going to want to palpate the patella. You're going to want to palpate kind of around the patella. You can do a little like medial glide and palpate underneath, so the backside of the patella, and then the medial femoral condyle, the medial plica, and you're going to see if they have pain in those areas. When you test strength, which is something I think you should do unless they're in so much pain that it's not worth it, and maybe you test a little bit down the road. But compared to healthy controls, patients with patellofemoral pain tend to have weaker quads measured by a handheld dynamometer. And this is something that we have to be careful about, because do they have quad pain that led to the patellofemoral pain, or quad weakness that led to the patellofemoral pain, or do they have quad weakness because they've had pain for a while, and we know that pain inhibits strength? So something to keep in mind, but you can expect to see reduced strength on that side. This was only validated in a study that was looking at risk factors in military populations. And I believe that was looking at, is it causative of patellofemoral pain? So they found in this group of military recruits that when they had tested with weaker quads early on, those individuals had a higher rates of patellofemoral pain. But again, that hasn't been replicated to my knowledge. I haven't seen that as a definitive risk factor. Quad inhibition is seen on surface EMG and may contribute to weakness. And that indicates there likely is some changes in the efferent motor output from the brain to recruit the quads. And that makes sense, right? Because we talked about that when you do contract your quads really, really strong, you may be increasing compressive forces on the patellofemoral joint, and it's probably the brain's way of trying to protect you from pain. And we did mention this a little bit earlier, but you might see decreased hip abductor and extensor strength. And then this was a quote from the clinical practice guidelines. There's a strong possibility that hip weakness is a result of patellofemoral pain and not a direct cause. So just make sure you're still separating those two in your head, but something clinically that we'll definitely be able to work on.
Yeah, it's and just to kind of double down on what we were talking about previously, and this is most of what I've seen as well in a multitude of studies, is that it doesn't appear that having hip weakness is going to be a risk factor for developing patellofemoral pain, but for some reason, folks with patellofemoral pain will present with decreased hip strength after the fact. There's even a couple studies, I think there's two that I've seen, that showed that having a stronger hip was associated with patellofemoral pain, right? Now, that's we can kind of surmise maybe why that is. If you're moving more through your hip, you might be having more hip drop, more hip internal rotation. Maybe you're jumping, landing, running, and that's how you like to control forces. So essentially, the hip is you're choosing a hip strategy in order to do your activities. Does that lead to more lateralization of forces within the patellofemoral joint? I have no idea, right? We're just guessing at this point, but just want to say that it is not clear cut, right? So essentially, these folks will probably have weakness afterwards, probably not beforehand. Does being strong present a problem? I don't know. You'll find that in a couple studies.
All right. And then clinically, if we go through a movement exam, people with patellofemoral pain, they may walk, run, or negotiate stairs with reduced knee flexion compared to a healthy control. So you might see a little bit, they're less willing to load that patellofemoral joint. We also may see increased frontal plane movement during a single leg squat or step down tasks, and hop and landing are seen, or hopping and landing. So they're jumping, they're landing. They may be landing with that stiffer knee on the aggravated side, and probably again to avoid loading the joint. So you want to look for these things when you're going through your movement exam. Are they demonstrating some of these strategies that they're trying not to absorb force in their knee so much? They're doing some of these tasks with a stiffer knee. And it's unlikely that these are causes of patellofemoral pain, but working on them, it may reduce pain, or it may help rehab as we work through the rehab process. So it's something we should address, but it's something that you might see on the exam. So you go through your subjective, you go through some of your objective tests, you're feeling more and more confident about this diagnosis, and then you see some of these strategies on a movement exam. I think just keep giving you confidence that you have the right diagnoses and things to address in rehab.
Kind of going back to the idea of correlation versus causation. One of my thoughts too that I like to tell folks is that if your knee hurts and you're trying to navigate any sort of knee intensive situation, more knee flexion increases stress in the patellofemoral joint when you're loaded up, right? So what are some strategies you can do to reduce some of the knee flexion? Well, you can go into valgus. You can drop that hip, right? You can shoot the hip back. So you see these aberrant motions after folks have patellofemoral pain. And a lot of folks say, oh, that's the reason why you move poorly. That's why you have pain. And that could be part of the reason why you ended up in pain, right? I'm not trying to say it's not, but the other no-brainer is like, dude, if your knee is killing, of course you're going to move differently, right? So just keep that in mind. Now, you see this quite a bit. And then in terms of what to do from a treatment perspective, we'll talk about that in a future episode.
All right. I think, Dan, this is your favorite part of patellofemoral pain, right? Kinesiophobia.
Yeah.
You want to touch this slide?
Kinesiophobia. Yeah. So I snuck this slide into Kevin's presentation just because I did want to know a little bit on psychosocial issues surrounding patellofemoral pain. And it's always interesting to me because I think these psychosocial issues are probably going to be in most conditions. It's just that we only start to find this out when we start to study them. So you won't find research into psychosocial issues in certain pathologies, but it doesn't mean it doesn't exist. But we're finding these in patellofemoral pain as well. This is a study by Hott et al. In 2022. Basically, patients with patellofemoral pain had elevated levels of kinesiophobia, which, depending on the study you look at, is going to correlate with pain levels, right? And this makes sense. If your knee is killing you, you're not going to want to load it very much, right? So maybe this isn't rocket science, But those folks also tend to have more emotional distress. Again, if your knee is killing you, maybe that's making you stressed out. They also have higher rates of widespread pain, which is an interesting one. I'm not sure if that's due to the stress, kinesiophobia, or we're just seeing that maybe patellofemoral pain is going to be related to folks that are more sensitive, potentially. Not really sure what that means, just kind of brainstorming. And this was compared to the general population or pain-free controls. The other piece, which I thought was good and something maybe we can try to push, is that folks with patellofemoral pain that had higher self-efficacy, that was associated with better function, health-related quality of life. So we'll talk about this in the next podcast episode, but essentially we want to educate these folks and maybe use a few treatments that reduce kinesiophobia and kind of promote that self-efficacy, right? Because maybe we can push these people into a better place, improve their outcomes if we address these things. So any thoughts on that, Kevin?
Yeah, I think that's a good point that kind of made me chuckle a little bit when you said that this exists in other conditions. It's just that if it doesn't, it's just because it hasn't been researched yet. So I thought for the longest time that only back pain and neck pain were associated with kind of those psychosocial issues, because those are the ones you hear about all the time. But yeah, obviously it relates to many, many things, right? And people don't know. They don't know that, does this mean I'm going to get arthritis if I have this type of pain? Am I going to need a knee replacement? And, those are things you want to talk to your patient about and reassure them that there's things we can do for this, because I think a lot of times, especially now, you just Google everything and you Google knee pain and it says you need your knee amputated immediately. And they're going to be fearful of that. So yeah, that's a good point. I think we got to think about that with every pathology we treat.
Yeah, no, I don't want to get too far off topic, but that's a huge problem for consumers. We always talk about with nutrition because there's like crazy amount of terrible nutrition advice out there. So much so that like it is very hard as a consumer to figure out what's okay and what's not. I think that's, presents similarly with pain problems, right? And we think nutrition is a huge issue that everyone needs to know about, right? And obviously it is. But then if you look at some of these stats, like low back pain is going to be the second most common issue that patients present to a primary care physician with. And then knee pain is right down the line there. So it's like in the top 5, top 10. This is a global problem that people are facing throughout the course of their lives. And I think the available evidence we have, or like information that the average patient has access to, is not always the best. And that's a big problem. So, it stinks, but obviously we're out there trying to push evidence-based care. Hopefully it catches on. My YouTube channel is far less popular than other folks that don't have a similar approach. So take it for what you will, but that's kind of how things are currently. So
yeah, last thing I'll say on this, and then I had sent you, like, obviously won't name them, but someone random's Instagram where they had 200,000 followers almost, and they're just, everything we're saying right now about patellofemoral pain, like it may or may not be correlated with excessive foot pronation or with increased Q angle. And this page just has like, you're dealing with knee pain because you're pronating too much, and like here are exercises to work on your foot supination. It's like, so yeah, you're right. Consumers, this is the type of information they're often consuming, and then they're fearful of pronating their foot because they're developing kinesiophobia around that because they think it's gonna make their knee pain worse. And yeah, you got to keep fighting.
And they come in to see you.
Fight. Yeah.
And they're like, Q angle's off my foot. Look, it's so flat. We got to address that, so on and so forth. And yeah, maybe, but like the thoughts make it a little prohibitive to have success because they get so wound up in these beliefs. And then you're trying to push them in the right direction without turning them away because they see that your information is against what they've learned and they don't like that, right? And that's hard. Hey there, you little learner. Do you like this content and want to go a little deeper with that learning? You should join us with our online community Insiders Academy. It's our premium subscription membership to help you become a better coach and clinician. We do a lot of good stuff at Insiders. We fill in those gaps in knowledge that school didn't teach you. We go over things like exercise technique and prescription, programming, periodization, strength conditioning principles, and advanced rehab. Let's get you proficient there. We also help to keep you up to date on the latest medical literature, even if you don't have time. And we do this with cheat sheets. And these are PDF downloads that catch you up to date on a given topic in under 10 minutes. And we've got a lot of them, over 50, and we're constantly updating them and adding new ones. It's pretty much the exact same thing as downloading all of our knowledge directly into your own brain. We also keep you up to date with our master courses. We cover pathologies in depth so you know exactly how to diagnose and treat patients with these issues. And we're really thorough, going over prevalence and prognosis, risk factors, anatomy, history, clinical presentation, diagnosis, differential diagnosis, patient education, and exercise prescription, as well as manual therapies. We have a whole bunch of master courses and we're always updating and adding new ones. Some of the big dogs are rotator cuff related pain, knee osteoarthritis, shoulder instability, femoral acetabular impingement syndrome, slap pathology, cervical radiculopathy, lateral ankle sprains, and radicular low back pain. Who doesn't love some searing back pain going down their leg? We also include case studies with every one of our courses. This way, you can see exactly how we diagnose and treat. Each master course comes with in-depth protocols, both non-op and post-op. This way, you know the exact exercise we'd like to use with videos of all movements, how many sets, how many reps, how do the exercises progress over the course of time, what are the relevant manual therapies when they're indicated, and exactly what you should educate your patient about. Hey, are you a physical therapist, athletic trainer, or physical therapy assistant and looking for some CEUs? Well, we got you covered, and you can even earn CEUs for watching the content you're watching right now. Finish up the master course, take the exam, get the CEUs. Easy peasy. With Insiders Academy, you also have community access. Basically, you can have all of your questions answered by me and the rest of our team at Fitness Pain Free. This way, as you go through the learning and you have a question, you'll get it answered. Best of all, you can get started with Insiders Academy for just $1 for a week-long trial. After that, it's $25 per month. If you want to save 2 months, get them for free, then sign up for the yearly membership. I'm going to leave that link with a discount in the description below so you can check it out, and I'll see you there. Now, back to your learning.
So back to patellofemoral pain. Does patellofemoral pain recur? You know, if you have this once, are you going to have it again? Unfortunately, probably. So the research shows that recurrence rates can be as high as 70 to 90%. And while traditionally viewed as self-limiting, I think this gives us some hope. Increasing research data suggests that patellofemoral pain is often recalcitrant and can persist for many years and may cause a decline in sports participation. So the reason why I said this is hopeful is because it's not self-limiting. We're not just going to wait and see if this goes away. This is one of those conditions that if we see a physical therapist for, hopefully we can help prevent this recurrence and help get people better. And then one study by Langhorst et al. Derives long-term follow-up data from 2 randomized controlled trials. And this was an N of 310, pretty good. The pain severity with the VAS score and function with the anterior knee pain scale were measured between 5 and 8 years after the onset of patellofemoral pain. And just for looking at recurrence, they had 60 of these patients completed a follow-up questionnaire. And then 34, so 57% of them reported an unfavorable recovery from patellofemoral pain 5 to 8 years later. So, you know, in this 60 patient group, a little more than half, 5 to 8 years after their diagnosis of patellofemoral pain, still weren't happy with how they were doing. Multivariate models revealed that baseline patellofemoral pain duration, so if you have patellofemoral pain for longer than 12 months and lower self-reported function, they were predictors of a poor prognosis. So I think you see this with a bunch of other conditions, but you know, if you have someone that comes in with patellofemoral pain who's had it for, you know, a year and a half, that's someone who might not do as well. Obviously, that's not always the case. I think if they get high quality care and there's things they haven't tried before that you can help them with, hopefully their prognosis is a little bit better. But just keep in mind that this does recur at high rates, and you know, it is common to have pain years and years later. But hopefully, again, we can help these folks avoid that.
Yeah, these are crazy stats. And I think this is always like my answer to the revert to the mean police, right? Like, it doesn't matter what you do, they're going to revert to the mean, right? And what's funny is, so patellofemoral pain making up 25% of all, orthopedic cases we see worldwide. Low back pain's even more common, has a terrible recurrence rate. And then rotator cuff related pain, which is going to be the most common shoulder pathology and is equally up there in terms of how often it presents. They don't have a good natural history, right? So at least in my mind, are there a few things that do kind of revert to the mean? Well, sure, of course. But these big ones, generally not. They don't have a great long-term outcome. So if you do exercise them, they do tend to do a lot better. And even when we do exercise them, we have a hard time getting this to go away. So I just do think that we need to be as good as possible as physical therapists. This is certainly something you shouldn't feel bad about treating. And if you just let it go, and we'll talk about treatments later, wait and see, it does badly, right? It doesn't do great if you just kind of let this go over the course of time. So I would say that you definitely do want to try to treat this one. You don't want to let it go over the course of time, and you're doing your patient a disservice.
All right, and then just a little bit more on recurrence, because yeah, some of these statistics are crazy. So Blonde and Hansen, they looked at 250 athletes from a sports clinic. There were 122 females and 128 males with an average age of 21 years old. And they were instructed to complete a program to strengthen their VMO. 5.7 years after, there was a follow-up questionnaire that was 5.7 years later on average. Only 27% of these folks were pain-free. So 73% still had pain. And then of that 73% that still had pain, 52% had pain, but it was decreased. 35% were unchanged, and 13% had an increase in pain. Affected athletic activity in 74% of cases, and it affected employment in 6% of cases. So, definitely something that we can help intervene on. These statistics are a little bit discouraging, but I also don't know if strengthening the VMO is the only key to success. So, maybe this study is almost a revert to the mean. I mean, who knows? But, I think that is, again, so 73% still had pain. So higher than the previous study, but, take it with a grain of salt with the treatment approach. But recurrence is still very high. So hopefully we can improve that a little bit with our treatments.
Yeah, I just want to kind of like reiterate what Kevin said. 6-year follow-up is pretty long-term, right? And we're finding that 3/4 of those folks still have pain. So this is kind of recalcitrant situation or condition that's really hard to treat. Folks are having very long-term pain. So it's not, reverting to the mean. And also speaks towards maybe we need to be better about our rehab strategies. And we'll talk about that in a future podcast, but, just VMO strengthening by its own, who knows, right? It is quad strengthening. So, we know that can be effective, but can we be more effective? Probably, right? And we'll talk about that in future episodes.
All right. So then just a little bit of conclusion slide, because I know we went through a lot. So patellofemoral pain occurs as anterior knee pain that may or may not be painful to palpate around or behind the kneecap. And it does increase with increasing knee flexion loads. Secondary to there being more joint contact surfaces and more quad contraction. So as you get more and more joint contact, if those joints are a little bit irritated, you're going to get some pain. And then as the quad contracts and it's compressing on the joint and it's really creating a lot of torque, could also create more knee pain. And then this is just a quote, again, I believe from the CPGs here. So the most frequently cited predictors of poor outcomes are that longer duration of symptoms before intervention, overall lower function, and worse pain. Kind of makes sense. Negative psychological stress and altered pain sensitization were present in patients with patellofemoral pain, as Dan talked about. And for the majority of patients, the educate and wait approach of avoiding pain-provoking activities is not effective in improving pain and function in the short, medium, or long term. So as we had said, not a wait and see approach, but something that we want to be proactive about treating. So yeah, a little bit of a summary there.
And then I'm just reiterating the same thing you said, but one of the things that pops up in my mind is that longer duration of symptoms prior to seeing someone, maybe earlier intervention is going to be a little bit better for these folks, right? Maybe we need to get them through the door a little more quickly. I think when folks think about patellofemoral pain, it's not a dangerous situation, but if you let it go for long enough, 6 years later, you might end up being in pain. Maybe we should make this a little bit more important in our eyes and our patient's eyes, and just let them know, I'm not trying to scare any patient, but typically patellofemoral pain is not something you're eventually going to need surgery for unless it develops into arthritis years and years later, but it can be debilitating for long periods of time. So I think that getting them into PT as quick as you can, right? And then doing a great job with your education, trying to give them hope, trying to address any of those psychological risk factors, and just kind of promoting them, pushing forward, trying to affirm their positive actions, right? So making sure they're staying active, not being fearful of movements. But the other part is they can't blow through a ton of pain. And, we're going to talk about this in the future. So, all right. So now you know the background information that is important for patellofemoral pain. The next part of this video, we're going to go over evidence-based treatments and how to apply them best to your patients to improve your outcomes. Here we go. So we're going over all the best treatments for patellofemoral pain. We're going to talk about patient education. We're going to talk about exercise. And we're going to talk about how to modify movement and whether or not you need to modify movement in your patients. I'm talking dynamic knee valgus. Talk about exercise for the hip, mostly posterior and lateral strengthening. Exercise for the knee, mostly the quad. Exercise for the foot, which is a bit of a new kid on the block in the past few years. And we'll talk about blood flow restriction because there's more research coming out about that, which is pretty cool. We'll talk about orthoses. So things like straps and braces. Should you use those in your patients that have patellofemoral pain? We'll talk about activity modification, and we'll talk about things like load management. We'll also talk about gait retraining, which is pretty good. We discussed this in the last episode, but patellofemoral pain, also known as runner's knee. Can we modify the way we run to reduce pain and improve our outcomes? We'll talk about that. Taping. Taping's been around for a long time. Mecondyl taping. Should you do that? Talk about manual therapies. Is that something that's beneficial for patellofemoral pain? And lastly, we'll talk about modalities. Everyone's favorite. Is that your favorite, Kevin?
Yeah, I was just going to say I'm excited to get into this because all I use right now is modalities. So I'm hoping you can educate me on other things I could maybe use, but it's just been modalities up to this point.
Well, I knew this was going to be a short podcast episode, but modalities are supreme now. They work better than everything else. I'm just kidding. That's not the case. But we'll talk about that in a little bit, whether or not you should use modalities. Okay. So the first, and maybe the most important, ever since we had our interview with Lori Mitchner, this has had me thinking a lot more about patient education. And we kind of spoke about this before, psychosocial issues, but we kind of knew that psychosocial issues were big in the low back and the neck because they were studied. But as we start studying other conditions, we're obviously finding that it is an issue with pretty much everything, right? And we're starting to find how important patient education is, right? So at least with rotator cuff related pain, if you just educate patients, and oftentimes education includes exercise, so make sure that you note that, the education can be as powerful as actually seeing a patient in person. So one of the things I've kind of doubled down on is looking more at the educational components in these research studies, but also making sure I'm doing a really bang up job with my patients with education because it really seems to be super important, right? So I'm taking a lot of this lesson today from Winters et al. It's a 2021 paper in BJSM. I also looked a lot at the clinical practice guidelines. That was 2019. So, oftentimes what happens is the literature changes over the course of time. So I think the dates become relevant from that standpoint. So largely what is included in these studies that use patient education for patients. So this is basic, and I actually have a link for you guys. If you want to check it out, you can see the exact patient education that was used in some of these studies. But largely, they educated patients on why does your knee hurt? So basic information about patellofemoral pain, what it is, anatomy, so on and so forth. Also risk factors for patellofemoral pain, pushing the importance of adherence and exercise for long-term resolution. In the last podcast show, we talked about how recalcitrant the situation can be. But if you look at studies that compare exercise versus nothing, exercise is definitely superior. So we want to make sure that we really push that. Talked a little bit about when to return to sport and how. We'll talk about that. There's a good paper from Michael Rathliff that I'll discuss in the activity modification session that you can use to guide your patients. A lot of these patient education packets actually contained exercises. So essentially, they had different phases. They said, phase 1, do these exercises. Phase 2, do these exercises. Phase 3, do these exercises as well. So when we talk about education in a lot of these studies, the education actually contains the exercises, right? So we know exercises are very important for patellofemoral pain. So exercises in the education, obviously important, right? They also talked about how to modify physical activity using pacing and load management strategies. More on that later. They talked about pain guidelines as well. And one of the things I will say is that they utilize their own kind of system for how much pain was acceptable. So we use a pain monitoring model a lot, which is 5 out of 10 or less than 5 out of 10 is okay, as long as that you don't have pain after exercise or the following day. And this was studied by Michael Rathliff. Essentially, he wants less than that. So 0 to 2 out of 10 is okay. Anything more than that is unacceptable, right? So keep in mind that this is a little different than most other studies, especially tendon studies. They didn't allow as much pain when they were modifying activities. They also give information on optimal knee alignment during daily tasks and exercise, and also our good old friend kinesiophobia. Now, this wasn't one from the winter study, but this was a different study, and they were talking about how you can address kinesiophobia successfully with education. So just basically talking to someone is helpful, reduces their fear of movement. And they also noted that certain interventions, which we'll talk about later, like taping and bracing, may be helpful just because it makes patients more confident to do regular activities. And that's a powerful thing, right? So these are kind of the things to go over from an educational standpoint. Once your patient comes through the door, you do their diagnosis. It seems like patellofemoral pain. You want to make sure you're running through these educational components, right? What do you think about that, Kevin? Do you disagree, agree, hate education?
Yeah, I thought that was great. And one thing that it made me think about is I've seen you post on this a couple times on Instagram where you ask if going through the injury process yourself is one of the most valuable things a PT can do. And I've been dealing with a hamstring injury on my own, and kind of all those educational things you just talked about are things I have been thinking about with my own hamstring, right? So you could picture the patient coming through the door who just knows a lot less about this stuff. And these are questions they have, and they may not ask you directly, but they're thinking, when can I get back to my sport? What do I have to modify during my life to reduce my pain? What exercises are going to help? How long can I expect to be dealing with this for? These are huge things that, they come to us for. And if they're not asking us, or if we're not educating them, they're going to be looking it up on their own and probably getting, answers that we might not agree with, or things that could be making the situation worse. So, first and foremost, education is like the best thing I think we have to offer. Yeah, I have no doubt if I had patellofemoral pain and I just talked to you for like 20 minutes about it, and you were like, here are the things you want to do, you gave me all those education points, I think I could navigate it without any intervention from you besides the education, right? So I think it's important, obviously, and yeah, something that when you go through your own injury, you start to really understand, like, pay attention to what you want to know about your rehab process. You can be sure your patients want to know the same thing.
Yeah, for sure. I don't want to go too far off track, but it's so wild how powerful your brain is after an injury, right? Like we're constantly hurting ourselves, right? Like I'll come
Mhm.
in like, jacked up my knee, fell off my bike, twisted
Yeah.
it doing jujitsu, whatever. And the first thing my brain goes to after having an injury is like, crap, I'm gonna have to stop for the rest of my life. This thing is gonna need surgery. Like goes in a bad place, right? And it's funny because like I'm logical, I'm rational, I do this for a living. I tell patients not to freak out about it all the time, but the first place my brain goes is freak out, right?
Yeah.
It's exactly where it wants to go. And I have to look at the research. I have to educate myself again. I have to reassure myself. I have to go through this whole process over and over again, right? And another quick story is I hurt myself back in high school when I was like 17, fell pole vaulting, really jacked up my shoulder. I was going to Rutgers University to pole vault, so it was scary to me. Went to a PT. I didn't get a good diagnosis, didn't get a good prognosis, didn't get a good plan of care. I didn't feel like I was being addressed for my issues whatsoever, and stopped. And then literally I just worked with another physical therapist that did a good job diagnosing and told me like, oh, you're going to get better. I don't think it's going to be a problem. Here's the step-by-step, right? And just someone educating me through that process made all the difference. I could buy in and I went for it. So, again, we're just hammering the importance of a really good session with patient education, laying out that prognosis. If people are going to get better, here's step by step. Here's where we're starting. Here's what to do. Here's what not to do. You're going to get better. Just pushing all those things, I just think is so important. So,
One last thing I'll say that I hear you say all the time to patients is that physical therapy is like making soup, right?
Mm,
It's that's an important part of that education is that you're tasting the soup as you go and you're adding different things, and you want to let them know that this first session's interventions and exercises, it's not the end product, right? We're like modifying this as we go, and it might take time, and just be honest about that too. We have to see how you respond to these things before we can say that this plan is what's going to get you there. So then when they do have some setbacks, that's okay. You talked about the fact that that's probably going to happen, and we have to keep adding different things to this soup to make it how we want it, right?
for sure. I always tell folks this is experimental. This is our best guess. And I usually laugh and smile afterwards, which I don't know if that makes patients feel badly, but it's you're guessing. We're trying our best here, and we're expecting that it's not going to be perfect, right? If we set that expectation of like, yes, we're going to potentially set you back. This might make you feel worse, but we're learning as we go. And that's part of it. So when patients do hit those rocky spots, they don't freak out. It's like, all right, well, this is normal. We knew this was going to happen. We just have to change it. No big deal. All right, let's next talk about exercise, the best treatment generally for patellofemoral pain. So Kevin talked a little bit about the train on the train tracks analogy. We spoke about this. It's educated a lot in, I think, in university settings, right? So this is a sunrise view of an X-ray. If you guys are not watching this, you're listening to this, I'd recommend checking out the YouTube version at some point. We're basically looking at an X-ray of someone's femur with the patella right on top of it. And you can see that trochlear groove, and that's that track. The patella sits right on top of it. So it's like the train on the train track, right? And essentially, in folks that have patellofemoral pain, they have aberrant motion, which essentially just means they usually move a little bit more from the hip, a little less from the knee. This could be because they have pain. So if your knee hurts, you're not going to want to move through the knee. You're going to move more through the hip. So the hip gets kind of like the blame. Hip's the problem. We know there's weakness in the patellofemoral joint. Weakness in the hip joint after folks have patellofemoral pain. So the natural conclusion is like, oh man, the hip was weak and that's why the knee hurts. We're finding that's not always the case. And really what I just want to push, and I already pushed this in the last episode, is that it's not cut and dry that, oh, you have dynamic knee valgus, that's why you have pain, right? But I will also say that if you have dynamic knee valgus, you do have the femur moving medially. And what that does is it lateralizes stress in the patellofemoral joint. So essentially there's more force, or the same amount of force, on a smaller surface area. And then over the course of time, when folks have patellofemoral arthritis, it's pretty classic. You'll see this joint space decrease on the side that takes more stress. So the lateral side of the joint ends up taking more stress. There's less cartilage. So natural thought is like, if we can get the knee lined up with the toe, it's going to allow more even force dissipation. Maybe over the course of time, we're less likely to have osteoarthritis. But I will say this is very gray. It's very gray. And the research doesn't always completely support that. And we'll talk about that in a second. So we just spoke about this, but knee in, right? Essentially, if you're doing a squat, and the obvious case, I have a picture of the here again, is if I'm squatting, my knees are coming in, that's going to decrease surface area available for the patellofemoral joint to dissipate forces, right? And this aberrant motion we're talking about in folks that have patellofemoral pain, we might see this in a squat, but we definitely see this in things like step down, single-legged squat, single-legged jump, and landing, right? But you may also see it with things like lunges or Olympic lifts. So we're largely trying to clean up this motion as best as we can. But again, it's not necessarily cut and dry. So I'm about to go into some studies here. Do you have any thoughts on this before I go crazy?
No, yeah, get into it. So far, so good. Yep.
Let's get in. Okay, so a few studies. This is from Dolock et al. This was a study that was included into the clinical practice guidelines, so the American Physical Therapy clinical practice guidelines. The date was 2019, so I think that date is relevant just because obviously this gets updated over the course of time. We don't necessarily want to hang our hat on old research. If new research comes out that kind of shows something different, right? So the clinical practice guideline does not suggest using visual feedback to improve patients' motion during things like single-legged squats, lunges, squats, so on and so forth. When I read that the first time, I was like, whoa, that's kind of odd. Why is this? And it was from this study from Dolock et al., which was from 2011, called Hip Strengthening Prior to Functional Exercises Reduces Pain Sooner Than Quadriceps Strengthening in Females with Patellofemoral Pain, Randomized Controlled Trial. So first thing on top of my head, this is in females, so it's not in everyone, right? So you don't really know if that's what, is going to be relevant to every single patient that comes through the door. The study didn't even seek to come to this conclusion, although the clinical practice guideline used this study to come to the conclusion, is that essentially they had two groups. One group had visual feedback, so eventually shown to keep their knee over their toe during exercises, versus another group essentially did not have that visual feedback. They didn't try to change someone's technique during things like lunges, step-ups, so on and so forth. So what they found is that at the end of the study, both groups, a group that they tried to change their movement and the group where they didn't change their movement, they just let them go ahead and work into dynamic valgus, whatever, it's all fine. They had the same improvement in pain and function, right? And the other thing they found is that there was no change in their step down between the two groups. So essentially, if you showed people how to do a given movement well, right, and they did that over the course of several weeks, and then you tested a step down, it actually didn't change their movement whatsoever. And this was during a step down, right? And my first thought here is that the reason why folks have dynamic valgus in a step down is oftentimes related to their ankle flexibility, right? We know that. There's a lot of research on this, right? So if you have people with stiff ankles and you have them do a step down, the reason why they have valgus is because they have stiff ankles. If you strengthen their knee and tell them to keep the knee lined up with the toe and then do the same step down, you didn't address the ankle flexibility issue, right? So that makes a lot of sense to me. And then you have future research. This is from Nunez et al. In 2023. They used internal feedback to try to improve frontal plane and sagittal plane motion. So essentially trying not to have dynamic valgus and trying to move through the knee. And that was part of their intervention for folks who have patellofemoral pain. And what they found is that when you did cue better movement, so less valgus, that did correlate to improved movement mechanics and outcomes, right? So essentially, in this study, it kind of showed the opposite. So it showed that if you cue people to have better motion, right, it does improve the outcome. And then if you test them on I think they used a step down as well as a single-legged squat, it improves their movements, right? So when I first saw that clinical practice guideline, I was like, oh my gosh, that's kind of weird. What's the deal with that? And then I saw this newer research, I was like, okay, well, that makes some more sense to me. But when I read those two studies, it's like, all right, it's obviously nuanced here, right? And there might be something to movement, improving people's pain, might not be. We're not completely sure. Any thoughts on that before we move on, Kevin?
Yeah, I guess what I'd take from that is that it's something I'd probably try and see if the person has a reduction in symptoms and they feel better. If it's someone who is going to spend a lot of time in the gym, probably want to work on, I'd want to work on improving those impairments so they can have a better movement selection. They can modify how they're moving to do different exercises better. Like if you're trying to really load the quad, you probably don't want to be going into so much knee valgus just because you're not getting the same pull on the quad. You're not able to load it as well. So I think it depends on the patient population and it depends on your goal. But for me, if I have someone that's showing that and they don't have a true ankle mobility issue, and then we change their mechanics and they feel better, well, then that's the way I'll have them squat or single leg squat. Maybe they feel better with that. Or maybe you throw a little heel lift. They can help with the ankle motion, and then they can squat and keeping their knee a little bit more in that sagittal plane, and they feel a little bit better. Maybe early on they adopt a little bit more of a hip strategy, and then as their patellofemoral joint calms down, we can load it a little bit more, bring it a little bit further forward over the foot, over the toe. But again, if it's someone who they're not interested in being in the gym long term, and we can't find a way to change these mechanics, then maybe that's okay. Maybe we don't have to. But yeah, I'm interested to see how the studies keep progressing over time with more information.
Yeah, for sure. My other thought too is that when you just clean up kind of hip and knee mechanics, you're actually driving more force through the patellofemoral joint. So maybe what we're doing is we're forcing more stress to the area that we want to improve. And that's why we see it improve things. Maybe not because we have less stress through the patellofemoral joint, because we're having better force dissipation. I don't know. It leaves me with more questions than answers, but it is interesting to see that. Plus, like, we see this all the time, right? Like one study comes out, it's done in a very similar fashion to another study that comes out later, it says exact opposite. So maybe, and I'm not the best with stats, but maybe like the sample size is too small or something along those lines, which in physical therapy research happens all the time. We have these really small sample sizes. So it might just be for that reason as well. But okay. So the next thing I want to talk about is strength the magic bullet? Because oftentimes we'll say, oh, you got patellofemoral pain. We just need to strengthen things. That's what's going to help you out, right? And essentially, the question becomes, does improvement in hip and knee strength correlate with reduced pain and improved outcomes? And this study was from Kim et al. In 2023, Journal of Sports Rehabilitation. Changes in hip and knee strength are not associated with improved clinical outcomes after rehabilitation in individuals with patellofemoral pain, a critically appraised topic. So this is interesting too, because it comes down to kind of our basic science and basic understanding of why exercise is helpful for folks. Because one of the biggest, reasons why folks will say exercise is helpful is because you have weakness and we're strengthening, and then we have increased strength, and that's why your pain goes down, right? Well, this study didn't show that, and like we're seeing more of this research all over the place. There's quite a bit of this research in rotator cuff related pain. So folks go through an exercise program, their pain goes down, their pain doesn't change whatsoever, right? We know that heavy loads work for people in pain. We know that moderate loads work, light loads work. We don't always need to make sure that strength goes up to make a change, right? So this is just a quote from this paper. They looked at 4 individual studies. So they combined a whole bunch of different studies to see. And they said there is consistent evidence that changes in hip and knee strength are not associated with improved clinical outcomes after rehabilitation in adults with patellofemoral pain. So one of the thoughts is like, hey, if we're not getting their strength up, maybe that's why they're not getting better. Well, it doesn't seem to be the case. So you can have increases in strength and not have reductions in pain. You can have the opposite. So you can have folks that have no increase in strength and then their knee pain goes down. So there's something else at play. I don't know what the heck it is, but it just kind of, I think it's good information to know, because it just leads you to believe it's not cut and dry, right? Because there's a lot of folks out there say, oh, you're weak, you need to strengthen. That's why you need to get better. It's like, well, we have pretty clear evidence, multiple studies, pretty good studies that show that's not the case. So again, the social media world, and I say it all the time, you just need to strengthen things. And maybe that's the case, but the strength doesn't necessarily correlate with the outcome. So interesting stuff nonetheless. What are your thoughts there, Kevin?
Yeah, I think that's important to differentiate. Like, strengthening might be great for reaching your rehab goal of getting back to weightlifting or getting back on the soccer field or football field, but it may not change your pain per se, right? And then I think you're right. We have to be a little bit careful about telling someone that, you got this pain because you're weak and now we have to strengthen. And if not, you're going to have this pain for a long time. Which is a common explanation. I think one of the more common ones is that you have hip weakness, you have kind of foot and ankle weakness, and then more stress is going through your knee, and we have to strengthen it. But like you said, we have a lot of studies that show that explanation is probably lazy and not exactly true. And there's a lot of things exercise does that we don't understand, right? It does more than just strengthen. It can help a lot of things. It can improve anxiety, improve depression, improve pain, right? So exercise can be helpful for these people, but maybe not just for the sole reason of it's getting you stronger. It's probably doing a lot more than just that.
Yeah. And last thing I will say is, like, I'm not hating on quad strength. I think it's super important, especially for certain populations like ACL reconstruction. We'll talk about this later, but quad strength is enormously important, right? So I still think you should measure it, still think you should work on improving it. It's just that the reason why we get out of pain is not clear cut. That's all. Still strengthen the quads, definitely strengthen the quads. Good to do handheld dynamometry testing, so on and so forth. I think it's still probably a good idea to do with your patellofemoral pain patients as well. It's just that, again, it's not clear cut. We're not sure why people are kind of getting out of pain. That doesn't seem to be the exact reason why anyway. All right. Let's talk about the different types of exercise therapy. So largely in our medical research, you'll see a lot of different types of strengthening being effective for folks who have patellofemoral pain. So largely there are a bunch of studies. This comes from the Winters et al. Study in 2021, as well as a couple others, which I've cited if you guys want to check out. So largely we're focusing on strengthening the hip, and that's usually the posterior lateral muscles. So think like glute max, glute med, those muscles specifically. Also strengthening for the knee, which is going to be more quad strengthening exercises. Also trunk strengthening. So think about anterior and lateral core, things like front planks, side planks, so on and so forth. and also a bunch of exercises for the foot and ankle, which I thought are interesting. I just included 2 newer articles from 2023 and 2024, I think. You guys are going to have to fact check me in the reference section, but there's been a few studies since the study from Winters et al. That were looking at foot intrinsic strengthening by itself, as well as with some manual therapies, I believe, and also short foot training, which is a blast from the past. Vladimir Yanda, right? The old short foot. So thinking that tripod position of your foot and trying to get the kind of first ray closer to the heel and create an arch. If you use a short foot, it seems to help folks have patellofemoral pain, and working the foot core or foot intrinsics also seems to help as well. So it's funny because we just talked about foot posture maybe not being that important, but when we apply exercise for the foot, it seems to help, right? There's also some cool research coming out about blood flow restriction training. So the clinical practice guideline gave a grade F for blood flow restriction training. And the major reason why is because there wasn't a lot of research out. But keep in mind, the CPG is from 2019. There's been more research that's come out since then. So a study by Constantinou et al. In 2022 showed that BFR was as effective as usual exercise of the hip and knee musculature. They also indicated greater increases in strength, reduction of worse pain post-treatment. So what's kind of cool is that BFR, at the very least, can be an exercise that you can use, or a type of exercise you can use in your patients with patellofemoral pain that's equally effective as other forms of strengthening. You and I know, if you've been a clinician for a while, folks with patellofemoral pain, if they have bad enough pain, all sorts of exercises hurt a lot. And one of the strategies you can do is you can tackle the hip, you can tackle the foot, just because those are structures we know that don't hurt. And we know if we strengthen them, the patient will improve. But we can directly strengthen the knee and the quad via blood flow restriction training because we're using such light loads. So at least for me, I generally try to strengthen all of these structures. But early on, I kind of hammer the hip, the trunk, the foot. And then I try to use things like BFR for the quad if the patient can't handle normal strength training for the quad, right? So I think that's a great adjunct. And the other piece is that the BFR literature is kind of exploding right now. There's been so many papers in the past 5 years looking at BFR for things like patellofemoral pain, and it does seem promising. So I like it. What are your thoughts on these exercises here, Kevin?
Yeah, anecdotally, I definitely agree with you. I think you made a good point, right? The clinical practice guidelines are from 2019, so things can change, and BFR is one of those categories of studies. One of the focuses of studies that more and more is coming out each year. So yeah, maybe that will change a little bit over time, but to me, it seems like a no-brainer that it's helpful for these folks, and it depends on how painful they are, right? But like you had said, if they're not tolerating knee dominant exercises early on, and you want to get a training effect out of the quads, blood flow restriction is a great modality we can use with people. So, yeah, we use it all the time at Champion for a lot of different things, but usually for those folks that are very irritable and they can't tolerate a lot, BFR is a great way to get a good training effect, and something I'd recommend.
Yeah, it's funny. Like, a lot of folks will discredit BFR. They're like, why using BFR? It has the same outcome as regular strength training. It's like, dude, my patients can't do regular strength training. Their knee is killing, right? And the other part is that it seems to help with rehabilitation, but also builds strength and hypertrophy at a very similar rate. In some of these studies, the BFR group actually beats out the regular strength training group, which still blows my mind, right?
Mm-hmm.
But it's at least as good. And if you have a patient that comes to the door that likes strength or fitness, or they're an athlete, one of your priorities should be keeping their strength and hypertrophy as high as possible, because when they get back to sport, we want to reduce that acute to chronic workload ratio as much as we can and maintain their strength. So BFR, in my mind, despite some of the outcomes being similar to regular strength training, so powerful when people can't actually do much because of pain. Okay. How about some other exercise therapy? So one that did pop up a little bit in that Winters paper was aerobic exercise. And I wanted to learn more about aerobic exercise and pain. There's been a couple cool studies recently about aerobic exercise, or walking, namely, for low back pain being very beneficial. And we see that a lot in low back pain. And like, how many times does a patient have knee pain, comes through the door in a physical therapy clinic, says, all right, hop on the bike, let's warm up, right? Is that actually helpful for patients, right? I would love to know. So essentially, I had to kind of dig into this paper to find the actual paper that they were referencing, and this was from Moyano et al. In 2013. And I honestly feel like this paper wasn't completely helpful because they were just looking at static stretching versus PNF stretching with the addition of aerobic exercise. And they didn't even give specifics on what type of aerobic exercise they were doing. They just said it was 45 minutes of aerobic exercise with a personal trainer 3 days per week for 4 months, right? So I was like, what the heck were they actually doing? But what I will say is if you do stretching in one group and the other group does PNF stretching plus aerobic exercises, the aerobic exercises with PNF stretching group did better, right? So is there great research to show aerobic exercise is more beneficial in other types of treatments or nothing? Not really. But I just thought this was interesting. And I like the idea of adding aerobic exercise to my patients' programs. Plus, if you're working with runners, which is a major population who gets this, right? If we can keep them aerobically fit and rehabbing them at the same time, I'm always looking for those kind of two birds with one stone situations. So I would say that aerobic exercise is an interesting idea, but the research is pretty poor on whether or not it helps, right? And then also, you'll see studies that do combinations of different types of treatments and exercises, right? And this is coming from the clinical practice guideline and multiple other studies as well. I think the Winters study said this as well. But when you combine hip and knee exercises, you generally have superior results to doing just hip or just knee alone. However, I will say that this is mixed, right? Kind of always has been. But there's a study in 2023 in the BJSM, and I think BJSM does a great job. Largely, the studies seem to be very good, and I trust them is kind of what I'm getting at there. But essentially, they tried to do an exercise intervention looking at the knee versus the hip or combine the two, and it looked like it was the same outcome, and it wasn't a great outcome either, so that kind of stunk. But largely, keep in mind, this is still mixed, but it does make sense to probably combine hip and knee exercises, or at the very least, choose the intervention that's going to best fit the patient and try to combine multiple interventions. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free Mini Course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. Any thoughts on that, Kevin?
Yeah, I think like you had said, a lot of the patients that we see with patellofemoral pain are endurance athletes. So they run, running is a very common sport where we see athletes with this issue. So obviously they're going to have to get back to some aerobic exercise. But yeah, like you had said, maybe aerobic exercise by itself isn't gonna solve the problem. Maybe we need more research before we say that. But that's interesting because that's not something I had really even thought about. But when you framed it like, yeah, I'll go warm up on the bike, um, is that something we should be doing with people? So seems like we need a little bit more research there. But again, like you had said there, that hip and knee strengthening seems to be a combination you see in some of these studies that are helpful. So I guess what I'll do with that information is if I have someone who's trying to get back to an endurance sport, obviously they have to do some type of aerobic activity. Maybe running is too much on the patellofemoral joint right now. Maybe we do something like swimming or cycling if that feels a little bit better, as well as those things that we know seem to be helpful. Maybe a combination of that quad and hip strengthening. Um, but yeah, maybe not something we have to give everybody. But like you said, we're trying to promote health and well-being in our patients, so they should probably be doing some type of aerobic activity anyway.
Mhm.
So a lot of ways you could think about that.
Yeah, like I'm always screaming this from the rooftops, but like if we can be more powerful than just helping people that have pain and give them some sort of exercise routine, strength training, aerobics, like we know those are so beneficial for so many different things. Like I'm going to try to do that. And my bias, this is my bias. Who knows if I'm accurate, but I can't see a world where doing some sort of aerobic exercise is not helpful for these folks that have pain. It's just a little disappointing, like with such a common pathology. And I was talking to Rob Mansky about this the other day, like the amount of biceps tenodesis, the amount of like the long head of the biceps pain that you see does not correlate with the research we have on the condition at all. It's kind of crazy. Like I really wish there was better research to show and guide us, but I would love to see some more research about aerobic exercise, knee pain, particularly biking, but also running, elliptical, that type of thing. Does that actually rehab patients? Because it seems like it's really helpful for low back pain. Why has this research not been, done on other areas of the body? It's funky. You just haven't gotten around to it. I think the research just hasn't been done yet. All right. So next we'll talk about activity modification. Now I really love this topic here because I listened to a talk from Michael Rathleff. I want to say it was probably in 2019 or 2020, right? Because that's when this study was done. And he brought up this idea of an activity ladder or a modification ladder, right? I thought it was so brilliant that I started immediately using it with all my patients with pretty much every single pathology as a way to do two things. So one, keep people exercising when they do have pain, right? And also as a way to get people back to the activities that were previously painful. So let's say you have low back pain, you can't squat. What can you do that's still like a squat? Maybe it's a split squat. And over the course of time, as you get better, we progress towards a goblet squat, maybe with the heels elevated. And then we work our way to a front squat, then back squat, so on and so forth, right? So Michael Rathleff actually studied this, but it was in adolescents with patellofemoral pain. Like I said, 2019, AJSM, so good journal. And they're looking at 10 to 14-year-olds. So you can't extrapolate this to every single person. Like 10 to 14-year-old, in my mind, is doing a lot different stuff throughout the course of their day than like a 30, 40-year-old, right? So just like take that with a grain of salt, although I still apply these, principles to my patients that are older. They had a 12-week program. And basically, they're giving guidelines on how to return to activity during rehabilitation. And what's a little different from what I do and what was done in this study is that they actually didn't start this activity ladder until week 8. So these patients have patellofemoral pain, and they essentially got exercises that were kind of progressive in nature up until week 8. And then at week 8, they started this activity ladder with the goal of being finished the activity ladder by week 12. And they also exercised during week 8 to 12 as well, but they incorporated this activity ladder as well. And the idea is that the activity ladder has progressively more challenging motions. I'll read these off in a minute. Sorry. And you progress the next level when you no longer have pain during that given step. So there's 6 steps in this ladder. Step 1 was easy walking or cycling at a low level. Step 2 was fast walking or medium to hard cycling. Step 3 was slow running. Step 4 was stair climbing. Step 5 was running and jumping at medium speeds. And step 6 was running and jumping at high speeds. Okay. And this is hilarious to me because this is an absolute no-brainer, which I think most clinicians are attempting to do, or at least they should attempt to do, to return people back to sports. But he just basically researched it, right? So once people got to week 8, they started this ladder. Once they had no pain during the ladder, and they were basically instructed to only perform movements that were a 2 out of 10 or less. I'll get to that in a minute. And when they were at no pain, they moved to the next step, kept on going, kept on going, kept on going. And then when they were able to get through this whole ladder, not hurting, they're able to start sports participation, right? And the last thing I will say is that this is all given during the patient education. So it's not like the activity modification was only up to the clinician to say like, okay, let's go to this stage now. Let's go to this stage now. They were getting this information from the get-go, and they were kind of allowed to make decisions based on how they feel, which I think is an important thing to mention anyway. Any thoughts on this here, Kevin?
Yeah, I like that a lot. I think that's really smart and something I have seen you use with a lot of people. So I think that activity ladder modification is a great practice to implement in all, you could see how you could use that with all different types of pathologies that we see as PTs. So I think it gives a little framework on how to think about that progression of rehab a little bit. So yeah, I feel like that author, he was on so many different papers for patellofemoral pain. So he's a stud.
Yeah, I'd like to get him on. I was going to try to get him on and talk about Osgood Schlatters, because he, is one of the first researchers to actually see if like exercise and activity modification was effective for Osgood Schlatters. I'm sure you probably learned this. I learned this. It's like, all right, you have Osgood Schlatters. It's self-limiting, right? You just push through it as much as you're able to, but nothing's going to affect it, right? It's not the case. But yeah, it's something that a lot of patients are told. So it's growing pains. You'll grow through it. Kind of the case, kind of not. So I would love to get him on the podcast. We'll definitely ask him whether or not he'll be able to get on here is another thing, right? We have our wish list of people we want to bring on. I always try to reach out, but they can't always make it. So hopefully, Michael Rathleff, if you're listening to the Fitness Pain Free Show, we'd love to have you on board. We'll email you in a little bit to ask. You know what I mean?
Yeah. Just quick. I thought this was funny because we talked. You told me that this week, and I'm pretty sure I saw someone like 2 months ago who had Osgood Schlatters, and I told them like, well, it's pretty self-limiting. So I think just to show that like, we're not perfect with this stuff. I'm learning new stuff all the time, and that's where it's so helpful to be surrounded by good coworkers, because I catch the dumb things I say, and then I find out how to get better information. But yeah, I mean, there's just so much to learn all the time. But hopefully, folks listening to this can not make, like you say in the intro, same mistakes we make. Because you said that, and I was like, oh God, I think I just told this kid that like 2 months ago.
Yeah. Well, I mean, it is self-limiting in the sense that like every injury is self-limiting. You know what I mean? So I think that it depends on how the patient takes it, right? The patient's like, oh, this is not going to get better, and I'll just push as hard as I can tolerate. Maybe that's not great, right? But if the idea is like, oh, limit your activities based on your pain, and then over the course of time with exercise, it should improve, then that would be, a better explanation of self-limiting that's helpful for the patient, right? And maybe more accurate. But
and that's the way I framed it. Yeah, to be fair, is,
good.
Who knows if this would just, I guess the thing I was thinking, like with patellofemoral pain, is if we don't treat this, is it just going to grow? Are you going to grow out of it? Or is this something that if we, obviously if we modify, you're going to feel a little bit better, modify the things that are most painful, but then what do we need to add to make you better? And that's where I was thinking, just give it time, modify what hurts. Here's some other things to work on. But yeah, we're always learning. So it just funny stuff.
Yeah, it definitely is. All right, cool. So now a favorite of both Kevin and mine. I think it's one of your favorites. Gait retraining. What are your thoughts there, Kevin? You like it? Dislike it?
That's all I think about.
That's all. I catch him daydreaming sometime. Like, Kevin, what's up? He's like, gait retraining. Can't stop thinking about it. Anyway, this was a pretty cool, well, I guess I'm going to bring up a couple different studies, but largely the main author, or the first author on the clinical practice guidelines, was Rich Willie. He's on our wish list as well, right? For patellofemoral pain. He's a running guy, right? And so I don't know, but I feel like he's probably one of the people that kind of tackled this whole gait retraining portion of the clinical practice guideline, right? So the clinical practice guideline, again, 2019, kind of down on gait retraining, just because I think the evidence wasn't particularly strong at the time, whether or not, gait training was helpful, right? And I think that we have seen the research get a little bit more robust over the course of time. But I think it's important to keep in mind there are several strategies to reduce patellofemoral strain while running that have been researched pretty well, right? So one of which is going to be increasing cadence, somewhere between, let's say, 5 to 10%, depending on the study. The one that you're staring at, if you're watching YouTube right now, this was a 7 to 10% increase in cadence. You can also try to adopt a forefoot strike, which we'll talk to Kevin in a minute, whether or not that's something you should try. Talk to Chris Johnson quite a bit about this. Sometimes it can create more issues than it can help, so you have to be careful. Minimalist shoe wear does tend to decrease patellofemoral forces. That's under the pretense that if you have a minimalist shoe, it's not going to feel good to slam your heel into the ground. So you might more adopt that midfoot strike, potentially land a little bit softer, potentially reduce the strain of the patellofemoral joint. You can try to decrease hip adduction or frontal plane movement. So essentially, if you run in front of a treadmill and you're the type of runner that you get a lot of knee in, right? It looks like your knees are kind of crossing over your body every time you take a step. If you try to pretend that there's a little space between your knees, decrease that frontal plane motion, that can potentially decrease some of the patellofemoral strain, reduce pain. And the last one, and this one I had to look into a little bit more because the idea makes sense, but the actual implementation of it I was curious about, is you can try to decrease tibial acceleration. So essentially reduce the impact whenever you hit. And this study here that I mentioned is called The Effects of 2 Gait Retraining Programs on Pain, Function, and Lower Limb Kinematics in Runners with Patellofemoral Pain, randomized controlled trial. It's 2024, which I thought was great. Love to see those new articles. Jose Roberto de Souza Jr., great name, was the first author. And I think this was open access. You guys can go ahead and check that out if you like. But essentially, they gave runners a cue to run softer or make their footfalls quieter. And the idea is to decrease tibial acceleration. And they actually had machine biofeedback. They put an accelerometer on the patient, and they had them run in front of this machine that would tell them if they're running with too much impact. And if they're running with too much impact, there'd be this ding, right? And essentially, they're trying to avoid the dings. So they're getting feedback to land a little bit more quiet, reduce impact. And what they found is that this was helpful. So this was helpful in reducing pain, improving outcomes. So I will say, before I let Kevin talk a bit about this, that for runners, I'm almost always trying to alter some of these if it allows them to run with less pain. So cadence being the biggest one, almost always try to change cadence. And then changing running technique, I'm always much more cautious with, because I think you can potentially just trade the stress off from one area to another and end up with a new injury. So I am a big fan of trying to keep people exercising whenever possible. Runners love to run. Some of this gait retraining stuff I find very, very helpful for patients to continue running and reducing their pain. So, Kevin, what are your thoughts on gait retraining?
Yeah, that's all really good stuff. I think I first heard about the increasing cadence through Tom Goom. And I believe when I heard it was an anecdote where he was dealing with patellofemoral pain, and he was talking about, or it was Achilles tendinopathy. I actually can't remember, but it was something where, it was affecting his running, and he adopted this, and then he dove more into the research and really found how this was helping people. But what we think is probably happening when you increase cadence 5 to 10% is, well, a lot of recreational runners adopt a lower cadence. When you increase cadence, some of those parameters you were talking about, whether it's heel striking, sometimes we see increased vertical oscillation that may force you to land in a way that's louder. So louder being a proxy of maybe not absorbing force as well, or maybe you have a little more vertical oscillation, so you're landing louder. The cadence is one of those. It's the thing that seems to change most other parameters. So you can picture if you're running at a cadence of maybe 155 steps per minute, you're going to have a longer stride length. And with that longer stride length, you're going to probably be initiating with a heel strike, and you may be a little bit more bouncy. So if you bump up the cadence for those folks to something like, 5 to 10% more, like you had said, maybe now they're landing with a little bit more of a forefoot or midfoot strike, and maybe their vertical oscillation is a little bit better. Better in the sense that it's reducing pain and they feel a little bit better. I think there are a few ways you can think about like what's optimal cadence. I think it really depends. But if you look at the professional runners, professional distance runners, because sprinters is going to be way, way higher, but professional distance runners, they tend to sit around 180. So whether that's optimal for every person, probably not, but you look at what the best people do, you can't find any elite marathoners whose cadence is like 160. So if you want to adopt the strategies of the best, maybe you increase your cadence a little bit. This is something that may feel funky for people early on because we self-select a cadence that makes us most economical. But with a little bit of retraining, you become more economical at your new cadence. So that's something to consider. In regards to the minimalist footwear, I could see why that would help, because you're not going to heel strike with a minimalist footwear. Just people tend to adopt a more midfoot pattern with that. But you kind of said this too, I know you talked about this with Chris Johnson. If we cue people to just land on their forefoot, or they adopt a minimalist footwear and maybe they're running a little more midfoot to forefoot, we're just shifting stress potentially, and maybe stress, instead of primarily going to the patellofemoral joint, maybe now more stress is going to the metatarsals or the Achilles tendon if you're forefoot striking. So it's just something to consider, is that if you have someone with Achilles tendon pain and patellofemoral pain, which can happen, and you tell them to start running forefoot all the time, they could just flare up their Achilles tendon. So just something to consider. Stress is stress, and if you're running, it's got to go somewhere, and you can shift it a little bit, but just be aware that you want to know where you're shifting it a little bit. And the last thing I'll say is Rich Willie, who, like you said, would love to have on. He talks about, for people with patellofemoral pain, his return to running programs start with uphill running. And the reason for this is that you are going to be running slower, probably. So less speed is less stress to the patellofemoral joint. And then also your stride length is going to be less. So you're less likely to be heel striking, which could be giving you some problems in the patellofemoral joint as well. So usually for these folks with knee pain, uphill running can be helpful. You can get a training effect without causing a lot of issues, versus downhill running. You have all that eccentric braking forces through the quad and the patellofemoral joint that may be flaring things up a bit. So just something to consider there is maybe we can play around with a lot of these different things in terms of gait retraining. So kind of take your pick in what you and your patient want to work on. But I think, like you had said, you work on cadence with a lot of people. I think that's always a great place to start. And there's a great app called Tap That Tempo, where you can watch your patient run, and every time their foot hits the ground, you just tap your phone and it tells you what their cadence is. And then, you can download metronome apps and you can train like that. Spotify has great playlists that have certain beat per minute songs, so you can train with that too. But that's something worth trying, and maybe someone, their pain goes from that 4 or 5 out of 10 at their self-selected cadence, and then now it's a 2, and that's kind of the pain that we were talking about using for this condition, and maybe they can get a training effect without getting flared up. So yeah, a lot of things to think about, but a lot of ways you could take it.
Yeah, for sure. You already said this. I just rehash. Like you're just trying to manipulate some of these variables so they can still run, right? Which I think is great. I guess 2 things: that at the very least, you can always have your patient say, let's see if we can just avoid hills, right? Second help, not because you're going uphill, but going downhill. The downhill is what gets people, right? Or maybe they walk downhill, run uphill kind of thing. It's also very easy to manipulate this on a treadmill. People hate running inside. I hate running inside, but I do run on the treadmill, especially during rehab. And the last piece is that if you're running uphill, it just trades that stress off. The hip and the calf is taking more strain too. So if you have a runner with a history of like Achilles issues or foot issues, you might bring those on. So you just have to be cautious with these things. We already mentioned that, but I've certainly seen that happen more than one occasion. So just be careful, that's all. All right, manual therapy. Is that helpful for patellofemoral pain? This is always funny to me because recently I've had a few videos about manual therapies that just like exploded, right, on social media. And I use manual therapies, but I use a lot of exercise-based stuff and shockwave, all sorts of things, right? I'm always like referring to physicians. It's like a piece of my puzzle of treating. And I guess I am a manual therapist, right? But it's a piece of everything else I do. But like a lot of folks have like thought I was like a manual therapy expert. I had like 5 people from around the world reach out to me and ask me if I wanted to do a manual therapy clinic. And I was like, whoa, I'm not an expert here. But it's just clear to me that people love manual therapies. It's kind of a hot topic. They like to do it. I think that it's rewarding because patients feel better after you do them, right? But what does the research say about manual therapies for patellofemoral pain? Generally, what I found, and this is actually pretty well studied, there's a lot of research on manual therapy for the patellofemoral joint. Although it's not the highest quality, but I was surprised to see so much, is that it may be helpful in the short term, less than 6 weeks, for decreasing pain in patients with patellofemoral pain. There are several studies integrating manual therapy into a comprehensive treatment program, showing a positive effect. Changes in self-reported function with the inclusion of manual therapy were shown to be significant, but not clinically meaningful. So essentially, including manual therapies might be good as part of an entire comprehensive program. I believe the clinical practice guideline recommended against manual therapies by itself, which makes sense to me. The effects are more short-term in nature, so less than 6 weeks generally. Improvements, long-term results are not going to be better than other interventions. And which interventions were they using in these studies? And these are what I thought were pretty interesting. So, patellar mobilizations. That was the big one. There's a lot of different patellar mobilizations they used. But the other one that was studied quite a bit, several studies, was lumbar spine manipulation or mobilization. And they actually did find reduction in people's pain after manipulating the lumbar spine. And I remember I had a colleague like almost a decade ago that was telling me about this. And I thought that was really interesting. I tend not to manipulate the spine when my patients have knee pain. But an intervention to try. I generally don't do as much manual therapy. I did read a study looking at runners with anterior knee pain, so patellofemoral pain, and a combination of stretch with foam rolling, soft tissue work. And what else did they use? There's some other intervention, but it actually was very, very useful in the short term for patients that have pain. So oftentimes when my patients that have patellofemoral pain, if they're really irritated, I'll do some soft tissue work on their quad, hamstring, calf. And I think that is kind of evidence-based. It's just that there's not a ton of research on that for patients, right? So I largely find with the manual therapy research, there's not as much research on massage techniques. There's much more research on mobilizations. All that might just be because of the journals that I read. I'm not sure. But, anecdotally, I will use a little bit of manual therapy via soft tissue mobilization. But this is a very small piece of the puzzle to me. And a lot of times I'm skipping this. I'm not doing any manual therapy in my patients that have patellofemoral pain. One interesting thing we'll say, and I'll kick it over to you, is that Dr. Keytrees, shout out to Dr. Keytrees. This is my professor in grad school, David M. Keytrees, did this study in JOSPT in 2018. So just want to give a little shout out. What do you think about this, Kevin?
Yeah, I think what you said makes sense. And what we see in the research is, when we do see manual therapy, it does seem like a lot of times it's the joint mobilizations. We almost never see like massage therapy. And anecdotally, I'd say it does seem to be a little bit helpful for people. And we work in a clinic where we have so much time with the patient and we're able to do these things. And it does seem helpful for some people. But yeah, long term, it's a small piece of the puzzle. We want to get our patients moving, and we want to get our patients into the gym and back to the exercises and activities they want to do. So, I would say I use it, but I really only use it because of the setting we're in, and we have the luxury of the time with the person. And a lot of times they want this. It feels good for them. But, if we didn't do it, is it changing things long term? I mean, it doesn't seem like it for sure, but maybe it's something that you can try. And if you have an improvement in symptoms, sure, keep it going. But if it doesn't seem like you're making much headway, you probably don't need to be hammering it with the person for the bulk of the session.
Mm-hmm. Yeah, makes sense. Manual therapies are fun. I think they're helpful for some folks. Patellofemoral pain, the study mentioned it, right? They're clinically significant, but are they clinically meaningful? Not in that study. Right. And there's a lot of studies they were looking at there too. So they're just taking a bunch of studies, jamming them all together. There's always problems with that. I would say if it really helps your patient, they really want it, go for it. I don't think that's a problem, but just keep in mind it's definitely not the best treatment for sure via the research we have. So how about other beneficial treatments? Were there any other treatments that were helpful for folks that have patellofemoral pain? And this was coming again from that Winters BJSM study in 2021. So other treatments that were found to be more effective than wait and see was a foot orthosis. So a prefabricated foot orthosis combined with education was actually as helpful as doing exercise and education, which when I first heard that, it made me laugh a lot, right? Because we're thinking so much about, changing people's movement, applying the right exercises, blood flow restriction training, like load management, all these crazy strategies. And it's like, all right, well, give them a pamphlet, put something on their foot. That works just as well, right? Which I thought was hilarious, but I think it's something we can't ignore. So obviously there's way more benefit to exercising, but just putting something inside of someone's shoe has been shown to be very effective as well. So it's also very, very cheap. It's one of those things that insurance companies probably use as a tool against us. We're like, what are you doing exercise for? Just put something in their shoe, right? Obviously, we know exercise is way more powerful for a variety of reasons, but I also think it's important that you understand that this research study did show that, which is pretty wild, right? Also, patellar taping and mobilization has been shown to be helpful, particularly when combined with exercise, orthotics, and education. So kind of combining everything. And lastly, I just said this, but combining everything together can be helpful as well. So if you want to do some exercise, education, taping, orthotics, all these things seem to be beneficial. And when you lump them together, they also seem to be beneficial. Any thoughts on that, Kevin?
Yeah, I think those things you had just said, I'd seen in the clinical practice guidelines, and just bring up Rich Willie again. He has a really good evidence-based course on, I think, advanced concepts in running injuries, something along those lines. And, he has a section on patellofemoral pain and, recommended, as he was one of the authors of the clinical practice guidelines, that we try these things potentially. You try some McConnell taping. We're probably not changing the biomechanics at the joint. It seems like maybe statically you are, but once they start moving, things go back to where they were anyway. But it can be helpful for reducing pain. So if it is, just throw some tape on, teach them how to do it on their own. Maybe it allows them to continue to train with less pain, and they can get a training effect. Same thing with the foot orthoses, or if they feel like they can do their aggravating things now without pain, then why not throw that in as well? So I think this is one of those conditions where thinking outside the box about what other adjuncts you can add could be helpful. And from my understanding, if it's not reducing symptoms, then they don't need to do it. They don't need to splurge. And from what I've heard Rich say as well, and this may be counter to what you just said, is that seems like over-the-counter foot orthoses can be helpful as well. So maybe they don't need those really, really expensive orthotics. Try it on. If it doesn't help, return it to the store. You just see if it's helpful. And then I think last thing I'll say about that is, we've talked about this, but just because these things seem to help doesn't necessarily mean that their foot posture caused their problems. But I think educating the patient about that is, maybe we're shifting stress while things are aggravated for a period of time. You probably don't need to wear these orthotics for the rest of your life. But maybe it's something for the short term, allows us to speed up this process a little bit. So just something to keep in mind.
Yeah, and I think that Nunez article also mentioned that doing some taping might help with kinesiophobia. I think they may have even shown that, which makes sense. My fear is that if they're scared of movement, we're telling them that you're only safe when you have tape on your knee. That might be creating some problems as well. But anything you can use that's pushing your patient in the right direction, it seems like these are all good things to try. And at the end of the day, you're just trying to develop a program that's comprehensive, obviously, and follows these evidence-based parameters, but you just make it specific to the patient's needs. You have a lot of options, choose a few. And then over the course of time, you'll find that patients improve, and it doesn't matter too much what combination you use. You have the opportunity to choose what's best for the person's in front of you. All right, so Dan, you just said you can use a variety of exercises, but what's the best treatment? I only do best treatments. What is the best treatment? So the superior treatments essentially were all of these following treatments. So just like I said, all of the treatments that I'm about to list performed similarly. So again, you can kind of try any combination of these. And this is from the Winters et al. Article, so it didn't include every single intervention, but I thought they were pretty comprehensive, excuse me. So they were basically comparing these intervention groups at 12 months compared to wait and see, essentially doing nothing, right? So education by itself performed the same as education plus supervised exercise, because the education group did have exercise, it wasn't supervised. Patellar taping and MOBs. I'm going to repeat this again because if you're not watching this, it can be very confusing. So the first group was education. Second group was education plus supervised exercise plus patellar taping plus MOBs. Third group was education with orthotics. Fourth group was education with exercise with patellar MOBs and orthoses. And the last group was exercise. And all of these treatments had similar outcome at 12 months. And at 3 months, the exercise and education group was superior, right? So if you slap that orthotic into someone's shoe, right, give them a pamphlet, 12 months, they're going to have the same intervention as exercise. But if you do exercise with education at 3 months, that's actually more superior. And last thing they said is that they do not recommend wait and see for the revert to the mean police, right? Was not recommended. So we know that these things are recalcitrant. It's hard to treat them first and foremost. Even when we do treat them, it's hard to get rid of them. When we don't, it certainly doesn't help, right? So those are the best ones. Anything else there? Anything to add, Kevin?
Yeah, the one thing I'll say is that we had, like you just said, we had talked about in the What PTs Need to Know podcast, how common this condition recurs. And, a year out, they're doing about the same, but who knows how they're doing in 5, 7, 10 years out. Is the group that's just getting the foot orthoses and the pamphlet recurring at the same rate? We don't know. So I think, use your judgment, use your, clinical expertise. But I guess my approach would be a combination of teaching them exercises to promote general knee health, educating them on when this might happen again, what things we know you want to modify, and what things we can fill that gap until you can get back to what you want to do. And then if you've had success in the past with your foot orthoses and you get in a flare up, maybe throw that back in there. And, we can work with these patients over the long term to, kind of prevent that recurrence. Our model is that people can text us with questions anytime. And, maybe that simple communication that we can have with our patients can reduce that long-term recurrence. So I would just be careful about looking at that and saying, it all does the same thing anyway. We just do what, this one thing. And, just think about the fact that we know 5 to 7 years later, 50 to 75% of these patients may experience this issue again. What's going to equip them with the best tools to get rid of it the next time it comes back as quickly as possible?
Yeah. I'm biased too. I'm not a huge fan of the orthotics, although I will tell people to use it in the short term. I think it'd be very helpful for that. Last thing I will say, again, an anecdote, but this has happened several times. I have a patient on my schedule right now. He has a flatter foot. And like a lot of folks have a flat foot, their problems are all blamed on their flat feet. And he's basically been wearing orthotic for the past 20 years or however long it's been. He's got some pretty bad posterior tib tendinopathy right now. Cannot flatten his foot out whatsoever in weight bearing because it's so painful. And in my head, I just can't help but think, did he get so weak and now he's so unable to move from the foot because he's been posting on the inside of that foot for so long, doesn't have to actually use his foot for shock absorption, right? And completely sheltered that tendon. And now we're having a heck of a time getting that strength back because you're looking at 20 years of potential weakness from that. I don't know. That pops into my head a lot. And I always think the orthotic thing is funny because when you have surgery, you wear crutches, right? And eventually, you get off your crutches. You don't wear them for the rest of your life. Why do you put an orthotic in and keep it in for the rest of your life? We're trying to unload and kind of shield a tissue from stress. And eventually we probably want to get off of that, right? I don't want to wear an orthotic in my shoes the rest of my life. That sounds horrible. But yeah, it is still an option. So I don't want to poo-poo it. And obviously I have a strong bias against it, but yeah, that's my thoughts there. So lastly, what is not recommended from the clinical practice guideline as a treatment? So knee orthoses, and this is based on grade B evidence that you should not use them. So braces, sleeves, and straps. So patellar tendon straps, sleeves that you go over top of the knee, different braces don't appear to be helpful for folks who have patellofemoral pain. EMG biofeedback for the quad. So that VMO research. Like we're trying to get that VMO firing. So let's put like a little electrode on the VMO and then have people do knee extensions and try to get that VMO to activate as much as possible. Doesn't appear to be useful compared to just regular treatment. Visual feedback for knee alignment. Got a couple exclamation points to question marks there, simply because we think that visual feedback is probably important, but that's mixed evidence. We're not sure. The CPG kind of hung their hat on one study, which I don't think is a great idea, but it's all we had. And then future studies have kind of shown different results. So I would still recommend trying to correct people's exercise technique, particularly if it helps them with pain, which we know it can. So dry needling had grade A evidence against its use in folks that have patellofemoral pain. So it's a definite non-use. Manual therapy is a standalone, same thing, grade A evidence. Make sure you don't use it on its own. And then our favorite biophysical agents that often make the list of don't use recently: ultrasound, cryotherapy, phonophoresis, iontophoresis, e-stim, and laser therapy. These are not bad treatments, but at least for patellofemoral pain, looks like they're not really indicated. Any final thoughts there, Kevin?
Yeah, just so interesting. I think the dry needling course I took taught about its systemic effects potentially, and then we learned in this that spinal manipulation can be helpful. So you wonder why, like, what is that doing, and what is dry needling not doing? But I'll have to reevaluate my practice because I do all those things all the time. That's all I do is those not to do treatments. So all I do is iso. What is it? Phonophoresis.
Phonophoresis is good. It's when you take your phone and then you just put it on their knee. Just around.
Yeah, maybe that's why my recurrence rates are so high.
Yeah, man. Dang.
I have to reevaluate. This was a good episode. I think I'm gonna take away some of the pearls you taught me here.
Cool. Yeah. And I will say, like, every time you see those like poor grades, it is, I think, a good idea to go back and poke into those articles and see why, right?
Yeah.
Because oftentimes you'll find it's not really fair, right? It's like, all right, they just gave this a poor grading, and I don't know if that's actually fair, or like which strategy they use, what's the technique, what do they needle, right? Maybe there's other techniques that would be more beneficial, just like you said. So I think sometimes you throw the baby out with the bathwater when you get a grade like that. People look at that like, well, we shouldn't use it. And then no more research studies are done. And then there may be certain techniques are useful in certain patients, so on and so forth. But at least that preliminary research, I didn't read it. I just looked at the clinical practice guidelines. So just so you know that, you'd have to go and check in and see what they said. So, okay, now you have some good idea of the best treatments from an evidence standpoint about treating patellofemoral pain, but you might not know how to put it together. Well, whoop, 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 whoop. There's a link that suddenly appeared over top of Kevin's head. And in this link, if you click on it, there will be a YouTube video from Fitness Pain Free that is about a case study of a patient that had patellofemoral pain, and we abolished their pain. We emancipated them from pain in that video, and I'll show you exactly how I did it. So go ahead and click on that link, and I'll see you in that video.